Hi, my name is Rakesh Arora. I'm a cardiac surgeon and intensive care medicine specialist in Winnipeg, Manitoba, in Canada. I'm also a past president of the American Delirium Society and a co-founder of iDelirium. For this year, we've decided to contribute to the global awareness of delirium by the iDelirium Marchathon. My contribution today to this, I think, incredible event is really why I got involved in delirium, and particularly in the post-operative patient for the past 10 years or so. I have these disclosures, which have no specific relevance to this talk, but I do want to also disclose that I don't want this to be a number of studies talking post-operative delirium, but rather be an overview talk about some general concepts and what I think are important for us to consider in the perioperative field that can help address post-operative delirium in our patients. For more details, I'll refer you to these three important documents on the screen for you now. The top one is the Enhanced Recovery After Cardiac Surgery Guidelines, which were produced in 2019. The Society of Critical Care Medicine Guidelines for pain, agitation, delirium, addressing immobility, and sleep disruption in patients in the ICU. And the American Geriatric Society Practice Guidelines for Postoperative Delirium in Vulnerable Older Adults. These are great references for your team that I encourage you to read more in detail, that I'll speak to in brief terms on this talk today. In addition, as part of the Society of Thoracic Surgery, we've put together a series of webinars pertaining to the perioperative care of the cardiac surgery patient. This one here is for postoperative delirium, where there's a short little webinar that you can tune into as well on the Society of Thoracic Surgery YouTube channel. Okay, so this letter really defines my why of how I got involved in this field. So when I started my career in 2007, I just finished my ICU training. And while I had been aware of delirium and its importance to some degree, we didn't really have a specific plan to address this in our post-operative patients. So this particular letter was written by a patient who had a significant agitated delirium after his surgical procedure. In the ICU, he unfortunately grabbed a pair of scissors and stabbed one of our nurses, and then had a very prolonged course there afterwards of having difficulties with infection, reintubation, and so forth, but eventually went home there afterwards. During his recovery phase, he wrote this letter where there are two quotable parts of this that I think are noteworthy for us to discuss. One, that he wrote this as a letter of apology, which seems remarkable that a patient felt compelled to write that. Certainly, we see delirium, unfortunately, quite commonly in the perioperative period. And we didn't obviously bear any ill will to this patient. The nurse who got stabbed, you could argue maybe a little bit, but for the most part, we assume this is part of care. We didn't have a good plan to address it, but we didn't bear him any ill will. The second line is that he was thoroughly ashamed of his behavior. And I think this really speaks to long-term consequences of delirium beyond the hard outcomes such as mortality and increased length of stay, which I'm sure many of you are aware now, but the psychological and mental health illnesses that can occur in postoperative delirium can be profound. And this particular patient shows some examples of that here. And again, I think having a patient go through a surgical procedure without an organized approach for your team to address this is probably incorrect in the current era. Again, I think we've recognized the hard outcomes that pertains to delirium. This is another example of a patient's experience with delirium after surgery. This is provided by one of my colleagues here, Barry Campbell, who's a geriatric psychiatrist who was kind enough to share this picture with me. And it really shows the anguish a patient had gone through during the perioperative period of extreme anxiety. And you can see the suture lines in the middle and so forth. So obviously a very visually graphic picture denoting this, the psychological impact of delirium in a surgical patient. As I mentioned, we're probably very familiar now with the issues of mortality, long ICU stay, and loss of functional independence following delirium and prolonged courses in the hospital that may ensue thereafterwards after a surgical procedure. Again, importantly, I think it's necessary for us to recognize that cognitive and long-term mood issues that may also occur. Again, I'll refer you to this other lecture series for more details. One of the things that we looked at in our patients here was what happens to patients upon discharge. And what we found was those patients who had delirium after cardiac surgery had poor functional survival. So good functional survival is defined as those patients who go home, they're alive and go their own home, versus a patient that expires, which is obviously a bad outcome. But also those patients that lose their independence to go back to their own home. So they require admission to a long-term care facility or some other sort of skilled nursing home where they've lost that independence. So we call this poor functional survival. To be honest, we made up this term, but we published it 4 times, so I guess it counts as a real term. But this is also an important consequence when you look at the overall journey of a patient. And in a broad term, what we call enhancing recovery after cardiac surgery. And this would be an example of someone's recovery that was not well enhanced following their surgical procedure. This paper is just sort of hot off the presses in the last couple of weeks, which is an important one, looking at the overall costs associated with delirium, not only its occurrence, but also the severity. An important quote that's pulled out from this, I think, important seminal article that's come out recently is really showing the overall economic impact, which I think we've recognized to be large, but really rivals those with significant cardiovascular or diabetes type illnesses, which is profound. I think this sort of impact on our healthcare system will only continue to get worse as we have inadequate treatment plans for these patients and an increasingly older and comorbid patient population coming for surgery. To drive this point home, this is a model that Jim Rudolph and I came up with a few years ago that really kind of describes the overall vulnerability of the older adult undergoing a surgical procedure. There is some baseline vulnerability of that patient where there's either cognitive dysfunction, atherosclerosis, nutrition, or frailty issues on top of psychosocial stressors that exist at baseline, in addition to what's getting them to the hospital to require the surgical procedure to start with. They undergo the surgical event itself, which is a pretty stressful event, particularly in those with low levels of reserve, or said differently, high levels of frailty or lower levels of resilience. Then it's the care that happens afterwards when they're in the ICU, say, for example, following cardiac surgery, or the post-operative ward and other surgical disciplines that don't require, routine admission to the ICU. The various hemodynamic perturbations that may occur, fluid shifts, either too much fluid or dehydration, medications we give, such as opioids or other that may contribute to delirium, are important. When you combine these 3 strikes for a particular patient, it can lead to worse post-operative outcomes. And so when we look at how we've been doing care for the perioperative patient for the last number of years, I think doing the same thing again is not going to be met with success. We have to recognize our patients are getting older and sicker, and we in general need a more comprehensive plan to identify and then manage the vulnerabilities in patients undergoing large operations requiring hospitalization. So this really comes down to this concept of enhancing recovery after surgery, and really addresses the entire surgical journey from when they're first presented for elective procedure through their stay in the hospital and then follow up thereafterwards. I'll speak a little bit more about this as it pertains to the cardiac surgery patient, but again, you can take this to really extrapolate to any surgical discipline. So to distill what I want to now go in the second half of this particular talk into 3 basic categories. I think the key principles you need to take away from this particular talk today is we need to look for delirium routinely in the perioperative patient. We need to find risk factors and find ways to address that. In those patients who have the opportunity for intervention before their surgical procedure, find opportunities to build up resilience or perhaps reduce frailty with concepts such as prehab, finding ways for improved mobilization and sleep promotion during their stay in the hospital, and finding ways to minimize medications such as opioids, or at least use them at the lowest effective dose for the shortest period of time to minimize the long-term effects of that, as well as the in-hospital effects, which I'll speak to a bit more in just a moment. In addition, it's still quite common, unfortunately, to use antipsychotics and other mood stabilizing type medications as routine in the post-operative patient, particularly in older adults who do have some delirium. Again, recent enhanced recovery after cardiac surgery guidelines, as well as the important document from the Society of Critical Care Medicine in 2018 would indicate this shouldn't be your first-line therapy and really reserved for those patients who have significant troubles, of very disturbing symptoms, or are a safety risk to themselves or to other staff. Dive into each of these little categories or these segments in a bit more detail. We often talk about delirium in the post-operative patients as it pertains to the patient in the ICU, and that we use the common tools such as the CAM ICU or the intensive care delirium screening checklist, or ICDSE, in those settings. Patients often will get delirium on the ward, and finding a tool that works well in the post-operative ward is important, not only to use it routinely, but one that your team can recognize when someone's delirious at the earliest time point, that then therefore go look for the potential reasons for why it's occurring in the first place. I do have a particular paper shown on the screen here that we've contributed to recently, looking at one particular screening tool called the 4AT. And I encourage you to look at the 4at.com for more information on this particular tool. However, I want to make clear that I don't endorse any specific tool or have any particular financial interest in any one of these tools anyway, but rather that your team develops a systematic process to look for this in your patient that fits within your clinical context of your particular group. If you have someone that may be identified as being high risk, either through your pre-op evaluation or in the post-operative period, there are a number of tools that can be used prior to giving medications when they do get delirious to minimize the risk of delirium. Recent studies have shown that prophylactic antipsychotics do not provide any benefit in terms of reducing the occurrence of delirium or its duration once it occurs. There are tools out there. That's one example here from Jim Rudolph from a few years ago called the Delirium Toolbox. Really kind of tries to address the various senses that can be impacted in the perioperative period, such as sights, hearing, taste, and smell, provide cognitive stimulation with some examples shown for you here, and also sleep promotion in the perioperative period, which is often in short supply for many of our patients, that can be quite disruptive. If someone does get delirious, that finding the potential cause is therefore really an urgent priority for your team and really treating this as a medical emergency. In our Society of Enhanced Recovery After Cardiac Surgery Society guidelines, we recommend this as a Class 1 recommendation, similar to the SCCM as well. In particular, I want to focus on two things of this mnemonic. And again, I'm going to state that I don't particularly endorse any mnemonic or other, and I remember almost none of them unless someone shows me a figure or a picture like this that helps me remind me what the mnemonic actually means. But one of the issues that we deal with commonly in the post-operative patient is obviously discomfort or pain. The medication used most commonly for those then are opioids. And it's been shown more recently that this may contribute to significant increased rates of delirium, but also long-term effects of opioids, now contributing to what we've now understood to be the opioid crisis within the North American context. Why? Well, pain is, unfortunately, as I said, very common, but most of this seems to be centered in the first several hours or a couple of days following surgery, after which the majority of patients actually have less issues of severe pain and therefore require less narcotics to treat that. What often happens, however, though, they have standing orders for opioids and they continue to get it while they're in hospital, and more importantly, they get it upon discharge from hospital as well. To shift gears slightly from delirium, but they are related, is really talking about the issues of opioids in our older adults. Certainly, we know that there are certain risk factors shown for here that make it more likely for a patient to receive opioids post-operatively. This is a really important article just published last year from the Johns Hopkins group. And many of our patients following coronary bypass and grafting surgery have significant new persistent opioid use following hospital admission. This now contributes significantly to opioid overdose deaths and significant costs, in addition to the in-hospital costs associated with delirium with these particular medications. So to address these issues, the Enhanced Recovery After Cardiac Surgery Society has provided guidelines that addresses a multimodal approach to reducing opioids that will hopefully have the impact of, again, improving mobilization, decreasing delirium, and minimizing overprescription and time of discharge. Again, when considering the whole patient journey, we need to start as far upstream as possible and thinking about this in the preoperative phase to start looking again for patients who are at risk for issues for perioperative discomfort, developing a plan and counseling with those patients to negotiate what that will look like in the postoperative period, knowing that we can't take away their pain completely, nor should we necessarily endeavor to do so, and develop a strategy with them to find methods to treat their pain, to provide it at the lowest effective dose for the shortest period of time as possible to allow them to recover. This is also one of the guidelines recommendations we had, where we had this being a Class 1 recommendation, based on really hardcore science, but based on a number of non-randomized trials from various surgical contexts where we think this may be a benefit. Okay, I'm going to summarize things up here. What I've described for you in general has been my evolution as a surgeon that I've hopefully imparted to our perioperative teams to evolve how we've approached patients who are particularly at risk for negative outcomes after surgery. In this case, we're talking specifically around the areas of delirium and also minimizing things that can cause delirium, such as overprescription of opioids, and finding multiple or multimodal ways to address this in the perioperative period. There have been several publications now in the lay press. There are two examples for you here from the New York Times, where they've had people who've had difficulties in the post-operative period driven by their vulnerabilities, or whether they've actually had delirium post-operatively. I think it's very important when we're considering offering an operation for patients that are vulnerable and high risk for negative outcomes such as delirium, that we have a plan. We have to ensure patients don't just survive after the surgical procedure, but indeed thrive with enhanced recovery type protocols that address all these vulnerabilities. And so when you're looking at an aging population with increased comorbidity, it may seem like it's an overwhelming task. And so the plan that we have to develop has to be a multidisciplinary or interdisciplinary sort of process that involves the patient and potential caregivers as well, to develop a plan that's comprehensive and addresses the needs for that particular patient. That does require some tailoring at that time as well. I've spoken a bit about enhanced recovery after surgery. When you think about disruptive technologies in medicine, this is a good example of that, I think. Delirium has multiple etiologies that can cause it, and in individual patient, the reasons why they may be delirious may be different from day to day. By using a comprehensive pathway such as enhanced recovery protocols that addresses the entire surgical journey, where you provide a bundle of items to help address all these individual vulnerabilities, may be what's needed to help reduce delirium in our older adult patients. This still needs to be determined in proper prospective and randomized trials, but this concept of addressing the whole patient is important, I think, to help address postoperative delirium rather than looking for it and treating with antipsychotics and so forth when it actually occurs. With there, I'm going to stop. And again, I've been very proud to be part of this organization for the last several years. This is our 5th year of World Delirium Awareness Day. I hope you enjoyed this talk and all the other talks that will come out through the Marchathon. And we look forward to your contributions from your teams on the actual day of March 17th to show us what you're doing through our social media campaign and Twitter and other social media platforms of how you've engaged, on how to tackle a delirium and improve the delirium awareness in your own local area. Thanks very much for your time. Appreciate it.